First of all, let me introduce our speaker today. The speaker today is Dr. Alberto Herrero Babiloni. Dr. Babiloni is a young clinician researcher, and I'd like to insist on that. He is a clinician, and he enjoys doing clinical acts and integrating his clinical practice with his research. So I think I wanted to start with this point. Now, we are happy to welcome everybody that is at this presentation today, and would like to thank you very much, Dr. Babiloni, for being present here. Now, just as a little bit of a short introductory topic, Dr. Alberto Herrero Babiloni is a dentist. He has a DDS degree from the University of Valence in Spain. Okay. He also has a master's in science from the University of Alberta, where Minnesota, sorry, of Minnesota, where he carried out a 2-year residence program and 1 year of research in oro-facial pain and sleep. So he is also now implicated with a number of research projects and carried out a postdoctoral studies with Dr. Gilles Lavigne and his colleague, Dr. Louis De Beaumont at l'Hôpital Maison du Sacré-Cœur. And his projects relate to the stimulation of cerebral activity using non-invasive approaches. Dr. Babiloni wanted to refine and to extend his knowledge or his interest in research, and is presently carrying out a PhD degree at McGill University with Drs. Marc Martel and with Gilles Lavigne as co-supervisor as well. We should insist here that Dr. Babiloni is a prolific writer, and he keeps amazing me every time that we look at what's coming out of our faculty, because being related to Gilles Lavigne, his name pops up from every month with some interesting new publications. He has also received a number of awards, and a prestigious one, which is the scholarship, the Vanier Canada scholarship, which is a very prestigious recognition. And he has also received a PhD scholarship from the FRQS, and the RSBO has also contributed to his study. So, Dr. Babiloni, again, thank you very much for being with us. La parole est à vous, et on vous écoute avec beaucoup d'intérêt.
Merci beaucoup. Je voudrais parler en français, mais mon français, ce n'est pas le meilleur. Alors, je préfère de parler en anglais. Merci pour la compréhension. Je suis désolé, but I'm going to continue the talk in English. Thank you very much for the great summary. So this talk is basically a very brief summary of my research interest and kind of my trajectory since I finished dental school, as I will highlight. So just to do a little bit of backup on my trajectory, I started as a dentist in the University of Valencia. It's a very nice city. We really like to eat oranges and paella, but we actually do not have programs in orofacial pain there. When I was finishing dental school, I was becoming very interested in this field. So then I was looking for places to go, and I ended going to probably one of the best universities for this type of training in the world. That is the University of Minnesota, where I got a residency training of 2 years and also like a master. Then seeing patients every day, I realized that about the importance of sleep and how many of them were complaining about the sleep problems and how sleep was contributing sometimes to their pain according to their perspective. So I decided to look for one of the best sleep researchers that was also a dentist at that moment. That was Gilles Lavigne. Perhaps some of you know him already because he was the previous dean of the university. But anyways, I ended with him doing some postdoctoral training here at the University of Montreal and with Louis De Beaumont. And then I decided to expand even more my area of research by doing a PhD in experimental medicine, which I am currently finishing, in the use of, as Dr. Nanci said, TMS to manage people with sleep and pain disorders. So if I will have to summarize my likes and my research interest and clinical interest, it will be this: the interaction between oro-faciale pain and sleep disorders, but also about how to understand better and diagnose this interaction and how to be able to manage it. So a good starting point for this lecture would be to start talking about sleep, which is defined as a behavioral and physiological state characterized by a partial isolation from the external environment. It's important to know that it is an active state. It's not like coma or anesthesia, and there is actually still limited muscular activity and reduced response to sensory stimuli, but we maintain still like responsiveness to sound, to other pains or danger. The meaning of sleep has been object of or subject of debate for many years, but the truth is like we actually don't know for sure why do we sleep. But what we know is like sleep is strictly linked with fatigue reversal and recovery, with immune function, with memory, and with psychological and physiological well-being. If you think about the most common sleep disorder, probably you think about insomnia, which is defined as difficulty initiating, less than 30 minutes, or resuming sleep. But also now it has been introduced as early arousal. So basically you wake up before than what you would like. It is considered chronic if you have this more than 3 times per week for at least 3 months. And you can see here that the prevalence is quite high. Recent studies highlighted that it ranges from 10 to 30%, so basically a third of the population across all ages. And as you probably know as well, is aggravated by mood disorders like, for example, anxiety and depression. Another common sleep disorder is sleep apnea. Also, perhaps you are very familiar with it because as dentists, we can collaborate in the management and screening of this disorder. Is defined as a complete cessation of breathing for at least 10 seconds. This is an apnea, or partial cessation accompanied by a certain amount of oxygen desaturation. This is hypopnea. So a nice way of defining it would be like apnea is like if you have a piece of cork in your throat and you try to breathe and you cannot. And hypopnea would be if you have like a thinner straw, like the ones that you use to drink, for instance, like where there is still some resistance, but you can breathe a little bit. The prevalence of sleep apnea ranges a lot, and it has been reported that depending on the definition, it can go from 9 to 38%. So you can see like it's similar to insomnia. The classic sleep apnea individual would be like a male, obese, and older, but we're seeing that there are other populations at risk, like postmenopausal women. We still don't understand completely why, but we are doing research on that, so hopefully we can give a better explanation. Sleep apnea can be divided in obstructive, if it's more related to collapsibility of the pharyngeal areas, central, if it's more related with brain mechanisms, or both, which it would be mixed. And the most common one is obstructive. The way we usually measure sleep apnea is with this index called AHI, apnea hypopnea index, but right now it's very debated because it doesn't seem to correlate very well with long-term outcomes, like cardiovascular outcomes. So all the sleep community is thinking about how to redefine this index or how to come with a better index that can measure better or can be more clinically useful, if you wish. Now we move to pain. That was recently defined in 2020 as an unpleasant sensory and emotional experience. Be aware here of the emotional part, associated with or resembling that associated with actual or potential tissue damage. So here, I think it's clear that the authors also want to bring to the attention of the reader that nociception is different than the experience of pain. And that's something that we really need to realize also as dentists. When it lasts more than 3 to 6 months, it's considered chronic or persistent. And the prevalence of chronic pain among the Canadian population is as high as 21%. And unfortunately, it seems to be increasing across all ages, including young people. If we focus a little bit more in orofacial pain, a broad definition would be pain localized in the face and or oral structures. But what is the face, right? It's hard also to define sometimes. So there is a little bit of controversy. What is orofacial pain? What is headache? Should we include the forehead in orofacial pain? Because there are some pains that they can come from the first branch of the trigeminal nerve, and they can actually refer to maxillary branches or teeth or mandibular teeth. So it's not so clear-cut how we define orofacial pain, but a very classic and straightforward definition would be that orofacial pain involves the second and third branch of the trigeminal nerve, and this would be taken care by the dentist, and the first branch of the trigeminal nerve would be more related to headache, and that would be taken care by the neurologist. Again, I want to mention that this is a little bit blurry, and is not always the case. There are different types of orofacial pain. Probably the most common one is when it comes from the tooth, is odontogenic. But here I would like to highlight that there are other types, many other types of orofacial pain, and which is more important, all of them, they can, or most of them, they can refer to the teeth. So it is quite important for the dentist that we are aware that at least this exists. Other structures that can refer pain to the teeth are the muscles, the temporomandibular joint, the nerves, blood vessels. Perhaps you have here like migraine can also be referred to the dental structures, and we can have a migraine dental pain. And also when we don't know the cause, we call it idiopathic, but it's my belief that this is because we still don't understand the mechanisms, and in a few years we will call this differently. Regarding the prevalence of orofacial pain, we see that it's very similar to chronic pain, around 20%, perhaps a little bit more, except here in Brazil that it seems to be quite higher, and it also depends on the definition used, if it is like 3 months or 6 months, what type of orofacial pain includes, what's the population. But the point here in this slide is like it's quite high too. Orofacial pain has serious consequences. It's often very debilitating. It impairs social function a lot. We do not have to forget that we are talking about the face, that we use it to eat and to communicate. And it has a tremendous impact in the physical and psychological health of the person, including sleep. Because, and this is a perfect link with this slide, perhaps you know, but sleep and pain are highly comorbid. They highly coexist, up to the point that around 80% of patients with chronic pain report sleep problems. This is also similar in orofacial pain, where almost 40% can present with insomnia in a tertiary pain clinic. And very important meta-analysis gathering some studies with orofacial pain or different types of, chronic pain, not orofacial, saw that up to half of the people that were studied presented any kind of objectively diagnosed chronic pain. In this case, insomnia and sleep apnea were the most common ones. And in this meta-analysis, we also saw that chronic pain patients present several worse outcomes than healthy controls, including a worse sleep onset latency and efficiency. So they take longer to fall asleep. And then when they fall asleep, they perhaps they don't stay so long in bed. They spend more time awake, and they have more number of awakenings. If we focus more on TMD, which is probably the most non-dental chronic orofacial pain condition, there is a huge body of literature supporting this association between sleep and pain, but I would like to highlight perhaps the two most important studies in regards subjective data and objective data until the present moment, at least in my opinion. And thanks to the OPERA study, we have learned that individuals with, this is a prospective study with a lot of patients and very well funded by the NIH. thanks to that study, we see that individuals with insomnia are 1.32 times more likely to develop TMD or painful TMD. This is also very similar with sleep apnea, a little bit higher actually, and that sleep quality deterioration precedes TMD. So you can really see over time how sleep quality decreases before painful TMD develops. This is all with subjective data. If we take a look with objective data, there is this nice study that was done by the group of Karen Raphael in New York that showed that TMD female cases, they recruited 124, that is quite impressive for a polysomnography study, had higher percentage of light sleep and sleep instability when compared with matched controls. And this was recorded 2 nights for each to reduce the first night effect. But this does not only happen in TMD. We also see like other facial pains are significantly associated with sleep. For instance, we know that it's a well-known trigger for migraine, sleep problems, that is also highly comorbid with tension-type headache. And in regards other syndromes like cluster headache and evening headache, these type of disorders, they happen during specific phases of sleep. So yeah, we know like sleep is important for other facial pains too. This also includes trigeminal neuralgia, other types of neuralgia like postherpetic neuralgia and Burnet-Mouth syndrome, where it seems like is highly prevalent too. So if we think it's like, okay, we know that they are highly comorbid, they coexist, but which causes the other, right? We can ask each other that question. Well, during the years, and I would say like even up until now, we thought about this relationship to be bidirectional, where pain was increasing sleep and sleep was increasing pain. But this was also seen in a long term, in longer prospective studies, but also in shorter micro-longitudinal studies, where a night of poor sleep was followed by more pain the next day, and a more painful day was preceding a night of poor sleep. But the research seems to be more consistent or showing more consistently that sleep actually causes, or poor sleep causes the development of chronic pain, or at least contribute to it more than the other way around. An example of this is this important meta-analysis done by the group of Nicole Tang in the UK, where they gathered information from 61,000 participants from the general population, and they show like a decline in sleep quality and quantity was associated with 2 or 3 times more chances of developing any kind of pain condition. A very recent study by this Scandinavian group showed that also sleep is a risk factor for pain spreading. Basically, if you have a localized pain, after a few months, if you are sleeping bad, the pain can spread to other locations. And actually, we are seeing very similar things with one of the studies that we are conducting currently at McGill using data from the UK Biobank. For those of you who are not familiar with the UK Biobank, it's a very large population study that gathers data from 500,000 of individuals at baseline, age from 40 to 69, and then they are followed over time up to 3 waves. And now I think that they are gonna bring them again to have another wave. So this is very important because we can see over time how these patients evolve, and they collect not only self-report information, but also like other biomarkers like saliva, also brain imaging, and a wide variety of very significant and important physiological measures that can help us to predict the development of diseases afterwards. And with the data that we have in sleep and pain, we saw like self-reported sleep disturbances were associated with the development of chronic pain in different locations, and also were associated with the transition from acute to chronic pain. So those who had some acute pain at baseline developed chronic pain in the same location in one of these waves that was separated by like 2 or 3 years. So this highlights how important is to treat sleep early, to develop like this, to kind of stop this transition from acute to chronic pain. But I also wanted to put some emphasis in this UK Biobank and in this slide, because this is a clear example of how efforts between different institutions in the same country or can be combined. It doesn't have to be the same country, but how efforts can be combined to gather a very big pool of data, and then this can allow to reply or to ask important research questions. And I think like this is a little bit the future and what the researchers also should do, to think about these collaborative efforts. And so we are equipped to have like the proper sample to reply questions about genetics, or because I didn't mention before, but they also collected genetic information or fMRI, etc. So if we think about treatment for these sleep disorders that I mentioned before and chronic pain, we know that for insomnia, cognitive behavioral therapies, they preferred by doctors and patients, but we also have medication, physical therapy, etc. For sleep apnea, perhaps the most common and popular and gold standard is the CPAP, but we also have other ones like oral appliances that we do as dentists, myofunctional therapy that physical therapists do, etc. And for chronic pain, the whole variety also of these treatments, including also like oral appliances that we can provide. But there is a problem with this. It's like there is a high heterogeneity in these treatments regarding when we use some of those in some of the patients. So we see in the clinic that some of them, they work very well for some type of patients, but not for others. And sometimes we don't understand why. And what we are also seeing is like, whenever they are comorbid, these conditions, the heterogeneity increases even more. Moreover, like when these conditions coexist, sometimes they are treated separately. So the sleep doctor treats sleep, the pain doctor treats pain, but sometimes they don't talk with each other. So what happens is this increases the risk of polypharmacy and giving like more medications and increasing the possible interactions that the patient may have in the future, and then obviously the side effects and risks. So is it possible that because of all of this that I mentioned, we need a change of approach in looking at this sleep and pain interaction? Well, a classic way that is very popular is phenotyping, which would be a method for improving the understanding of diseases and enhancing management. Phenotyping is using genetics, but now it's also used in other fields as a way of classifying different clusters of individuals according to observable characteristics, traits, or clinical presentations. So for example, in regards pain, we can classify patients through their psychosocial state, through pain characteristics, demographics, etc., biomarkers like cortisol, quantitative sensory testing, or pain modulation. And we can do the same with sleep, with polysomnography values, subjective sleep quality, levels of arousal, in the way that we can actually understand, okay, are these patients similar? Are there some treatments that could work better for this, etc. So in that way, we can actually identify, use it in a short term, and identify some individuals that, for instance, could develop more pain fluctuations over time, which are known to be important. This is one of the works that we are doing in collaboration with my old colleagues in Minnesota and some of my colleagues here at McGill, where we saw like after administering a questionnaire, we classify patients into high and low impact pain, and those who were classified at baseline as high impact pain, they were having more chances, if I'm not mistaken, up to 5 more chances to develop pain fluctuations or pain exacerbations during the following weeks. But we can also see the prognosis in a long term, and we can see how diseases evolve over time, how more comorbidities are added to the equation, or how people like die also, basically. Another approach, which it could be more novel in a way, is the use of endotyping, which is also subtype different diseases or condition, but in this case, implying different pathophysiological mechanisms. A clear example of this is what the sleep medicine folks are doing in sleep apnea, where 4 different endotypes have been identified. One that is more related to anatomy or genetics, one that is more related with the responsibility of or how the muscles respond, other more related with brain mechanisms like high loop gain, and other more related with arousability. And in this case, this is a theoretical model that we did with Gilles Lavigne. In this case, depending on how what is the endotype of the participant or the patient, we can actually better target, or at least do trials to understand better with the perspectives of targeting treatments to improve the condition of sleep apnea. A clear example, if you want to dig even deeper, I'm not expecting you to read the small font. I just want you to capture the overall idea. But here, the group of Taranto Montemurro in Harvard or in Boston, what they did was to see one of those treatments, medications on all of these, the 4 endotypes that were found, and then describe very well which ones are working more or less for the different endotypes. So thinking about all of these sleep and pain relationships, it is possible that we can try to apply all of these concepts of phenotyping and endotyping to these patients that suffer from both, trying to improve the understanding of what's going on and how can we treat them better. So in that case, we could actually try to identify different vulnerabilities or phenotypic traits that the patient have that it could be behavioral, like things related to emotions or like wake or sleep. It could be more like genetic or demographic, or it could be physiological. And this could lead us to understand more the underlying sleep condition. Is it more predominant insomnia? Is it more predominant sleep apnea? And if that's the case, which of those mechanisms of insomnia and sleep apnea in their relationship with pain are here present? If we know already those mechanisms, perhaps we can target better with different interventions that we know that work better for when inflammation is present, for example, or when the patient is having more arousability, perhaps like cognitive behavioral therapy is better. If there are more peripheral components, perhaps like physical therapy or acupuncture may help, etc. So one of those approaches that I would like to talk today, because it's also part of my research, part of my PhD actually, is transcranial magnetic stimulation, also known as TMS, which is a safe and non-invasive brain neurostimulation technique that basically polarize neurons through magnetic pulses that you deliver with a coil similar like the one in the picture to the brain. And broadly speaking, TMS can be used for 2 things. One is when delivered in single pulses to assess cortical excitability and actually to phenotype patients and characterize them. And you can deliver these pulses in a more repeated manner. And depending on the protocol that you use, if it's inhibitory or excitatory, or sorry, if you use high frequencies or low frequencies, you can inhibit or excite different parts of the brain. So here you also may recognize Dr. Lavigne explaining how it works. This is very similar to the TMS machine that we have in our lab. We have also a dental chair, so you can have an idea of more or less how is the equipment and the room that is needed for it and all of that. And at the present moment, TMS is FDA and Health Canada approved for the treatment of depression, but it can also be used to treat like to improve recovery, muscle recovery after motor stroke, and also to treat schizophrenia. Regarding the side effects are very small and limited, being the most common one like a transient headache that goes away after like 10 to 30 minutes, and usually if it's a little bit more intense, it goes away with ibuprofen. I have to mention that in the past, there was some risk of seizures, especially with the older protocols. But now with the new protocols and with all the screening that we do where basically do not include patients with history of epilepsy and other things. This is very decreased to the point that there is almost no report in the literature about this. But very interestingly, TMS can also be used to treat chronic pain. It has been shown that when we stimulate the motor cortex, we can actually reach another structures of the brain because of the way TMS works, that the waves keep traveling. It's not only like where you stimulate, but also the adjacent areas. So you can stimulate different areas associated with pain modulation. And in that way, it has been shown that you can increase pain inhibition ability. So basically your ability of inhibit pain becomes like higher, among others, because there are other mechanisms that are still under investigation and not fully understood. A lot of animal studies and fMRI studies have shown that TMS mechanisms can involve several pathways like serotonin, GABAergic, opioidergic, related with chronic pain and well-being in general. It has been shown that one session only can have some short-term effects, but the more sessions you have, the longer acting effects you have. And it has been the most common reported duration of the effects is like up to a month after, for instance, like 5 sessions. There are actually some guidelines done by European experts that were updated a year ago, where they gather all the information available in the literature from high quality trials, and they basically stated that there is strong evidence to support the use of TMS in neuropathic pain. There is low evidence for musculoskeletal pain, as it seems not so clear like the location and the protocol. We did a systematic review a few years ago, and we saw like regarding oro-facial pain in general, there is low to moderate evidence, but at least is promising. And I also have to say that the Cochrane systematic review highlighted that there is a high heterogeneity in the studies and outcomes, and that the effect sizes they can be small, and larger and high quality trials are needed. And this is a perfect link to mention my PhD, which is actually about this. We are trying to use TMS with a sophisticated protocol and a very careful like design to basically study if TMS can improve TMD pain. I would also like to show like some other data from my lab that we currently have under revision in the European Journal of Pain, showing that actually TMS can help with the transition from acute to chronic pain, at least in patients with fracture. So as you can see in some of these graphs, especially, well, let's take a look to the upper graph, where it's studying people with like pain from 0 to 10. We see that in the short term, which is the graph in the left, upper left, there is like a decrease in both active and sham, which is expected also because of the course of the evolution of the fracture, but it's not significant. But when we see at 3 months, we see like in the active group, there is like a significant decrease in comparison with the non-active, and that this also happened with functional disability at 3 months. But importantly, when we see the data from a different manner, and we see the proportion of people who reported to have significant pain 3 months after the fracture, or in other words, like develop chronic pain, we see that, and you can see that in the graph in the upper panel, we see that the proportion is way lower in comparison with the lower figure, where there are more percentage of people transitioning to chronic pain, and those are the ones who receive the sham treatment. So in summary, it seems like TMS can be used also to reduce the transition from acute to chronic pain, as it facilitates recovery and reduce the burden of pain and symptoms. Regarding the use of TMS in sleep, there is some preliminary evidence showing the possibility of using sleep apnea and bruxism, but more research has to be done. And there is more emerging and promising evidence regarding restless leg syndrome and insomnia or sleep quality. Indeed, we published a systematic review last year in Sleep Medicine Reviews, which is a very important journal about this. And we saw that TMS was effective in improving insomnia when you were stimulating different locations, but that probably the most consistent result that we saw is when the left dorsolateral prefrontal cortex was stimulated with lower frequencies. So it will be more like an inhibitory protocol. And it is thought like it can reduce cortical arousal. So this makes sense because some of the people with insomnia, they may have high arousability, which would mean like it's easier to wake them up. And with this, it is possible that you can decrease that arousability. Moreover, it has been shown that it can help with the release of different neurotransmitters that promote sleep, like melatonin, GABA, etc., and that also down-regulates stress, you can say, or the HPA axis. This was more in the short term, up to 1 month, but this is a very recent paper. I think it was published last month or a couple of months ago, that show that these effects, they may last up to 3 months. So I think we are in the right direction here with TMS and sleep. And obviously, we have to look it into perspective that this is like not the panacea, and that it may be considered as an additional treatment, maybe as an add-on to people who are taking medication or that who are doing cognitive behavioral therapy to potentiate the effects of those. Also, why not? Like if we see the interaction between sleep and pain, is it possible that we are seeing that for sleep, the dorsolateral prefrontal cortex, it works better, for pain is the motor cortex, so why don't we do both to treat these people with this comorbidity? Well, this is one of the projects that we are thinking to do in Sacré-Cœur, and that I'm very keen and eager to start working on. I would like also to talk very briefly about other non-invasive brain stimulation techniques, just for you to know that there are other ones based on electrical currents, noise also, and it's another one based also like in the stimulation of the vagus nerve, which is external with a machine. All of those are still like there is some evidence in sleep, some evidence in pain, but we need to really see like, okay, not in this condition separately, but in people that have sleep and chronic pain problems, how this works and how much basically. There are also very recent publications, and I'm almost finishing, looking at how to optimize these TMS treatments with machine learning, neuroimaging, and also like how to combine it, like what I was mentioning before, with other treatments in order to potentiate it with antidepressants or with physical therapy, etc. Because ideally, the main goal and making like a wrap up and a summary of all that I mentioned before, the main goal will be to be able to have this big data available through a collaboration between centers, and then with that big data, we can be able to do like a machine learning analysis. We can be able to develop artificial intelligence algorithms and gather all this important information to identify endotypes and phenotypes. So basically to be able to understand better the patients and try to do like a more efficient personalized treatment based on the individual and their specific characteristics, rather than just give a recipe, the same recipe to everybody. And I think I'm finished. Thank you very much. Merci beaucoup. I think I am on time. But yeah, let me know please if you have any question or if there's something that is not clear that you would like me to expand or anything. Thank you so much again.
Thank you, Dr. Babiloni. So again, for Dr. Nanci, apologize, he had to leave for
no worries at all.
A meeting. So the floor is open. If someone has questions, he can ask Dr. Babiloni. I'm just going to check if there's any hands. So Dr. Kazman.
Well, I guess I have to start. Thank you so much, Dr. Babiloni, for your presentation. I should also congratulate you on the quality of the presentation, the slides that you've shown. There is a lot of work in this. I can see that. I was just wondering. I'm an oral pathologist and oral medicine specialist, so I see patients with pain, and I was wondering, is the TMS available in clinical practice, or are we still at the research stages? Is it available, and how can patients benefit from it other than in research settings?
This is an excellent question. I'm going to explain how is the situation here and in the US. So in the US is already approved for the treatment of pain. So there are like neurostimulation centers, and people can just go there besides the hospitals, and they can just have pain treated with TMS. Here in Canada is Health Canada approved for depression. So this is already available in many hospitals for clinical purposes. However, for pain, not yet. At this moment, as far as I know, it is more for research. And I have like a lot of colleagues contacting me, hey, I have this patient, I think they will benefit from TMS, like nothing is working, we would like to try that. Where do we send the patient? And I've been looking myself to try to find that answer, and it's complicated. So far, like I have not identified any center that really provides this type of treatment and being covered by Health Canada, and I think is in the future. Obviously, it is not expected that this is in dental clinics, but perhaps in more like pain rehabilitation centers or like hospitals or tertiary settings. And I think like perhaps we are leading towards that direction because we are accumulating a lot of good data showing like how these protocols can be improved to increase the effects, and usually like there is barely like side effects. So that's it.
Is it a question of cost as well? Is the cost of these treatments a barrier for patients?
So the cost of the machine, I can tell you, like it is expensive. I think it's around 50,000, something like that. But it's like an investment, I guess, of the center. At the end, it's more like a matter of, like it is electricity almost. That is what it converts in magnetic waves. So it's not really like, it should not be at least very expensive to deliver this treatment. But obviously, this also becomes more a bureaucratic question and more political that I'm not really equipped to answer, but I would love to get into all of this to understand why it's not available. Sometimes like we want it for now. So yeah.
Excellent. Thank you.
Thank you for the question.
Intisar had a question.
So congratulations for this presentation. So you mentioned that the TMS is effective to treat depression. Is it effective wherever the origin of the depression is? I give you an example. Sometimes the depression is caused by obstructive sleep apnea. It will be effective to treat that?
Well, so obviously, like you need to see when you assess the patient, like you see all the potential comorbidities and what is the origin of like what is probably like the leading condition. We say it like that. Is it like the you call it the sleep apnea, but let's call it like sleep problems. It's like the sleep problems, the cause of the depression. So obviously, like if you treat first like the origin cause, it is possible that you have more succeed to treat the depression, and not only TMS, but any other treatment may work better in the depression if the sleep underlying condition is treated. To reply more directly to your question, it is considered right now more an alternative treatment. So you will try first like the usual medication. This talking about only depression, okay? You will try like the antidepressants or whatever the psychiatrist consider that is the first line treatment. Then if it doesn't work, or if it is still not working as much as we would like, then an additional tool may be TMS. Obviously, you have to repeat this treatment a little bit, maybe in courses of like every 3 months. So it is not like maybe so easily implementable as other type of treatments, but I think it's getting there, and we have to see it as what it is, which is like a nice possibility and a nice access to the brain biochemistry change that we did not have before. I do not know if I replied exactly to your question, but if not, I can try to do it better if you give me some clues.
Oh, no, thank you.
Yeah.
Okay, thank you.
Thank you.
Well, actually, I had a question, and apologies, I'm not an expert in your domain, but so you're mentioning that TMS is good if you do it on a long, like multiple treatments. So if you know that someone has already prevalence for sleep disorders or any other disease, would it be possible to start a TMS before, like as a preventive, because we know they're going to do, let's say, orthopedic surgery or any other treatments? Can we start the TMS before and anticipate or minimize the pain? Is it possible?
You know, Rima, this is an excellent research question that somebody should investigate. I think it's quite great. And we were doing it for our study just after the surgery to see if we could like decrease all the pathways that may be related with more acute pain, to see if we could reduce the chronic pain later. But yeah, I think like not only about in related to sleep, but perhaps we could even target like pain networks before doing the surgery, trying to boost the system to see if that could reduce this transition or the development of acute pain. Perhaps there are studies looking into that. I'm not, I cannot think about any right now, so we should look into this, but it's a very good research question for a project.
Great. So was there any other questions? I don't see any hands. So if I don't see any hands, I would like to thank you again, Dr. Babiloni, for this excellent presentation. It was very interesting. And thank you everyone for attending the Dialogue sur la Recherche.